Okay, this is another autoimmune disorder. So you have an idea already. Autoimmune, so therefore, do we know the cause?
No.
What will the treatment involve? Immunosuppression again. By the way, with anyone taking immunosuppressants, what's the consequence besides Cushing syndrome? The patient will be at risk for what? Infections. Very good. So that's in addition to what we mentioned already. So patients with ITP were treated with immunosuppressants. So far, rheumatoid arthritis, and now myasthenia gravis patients. Okay, so they're all taking immunosuppressants, so we protect them from infection. So this disorder affects the nerves, particularly the myoneural junction. I'll explain shortly. So this will result in weakness of voluntary muscles. Voluntary as in skeletal muscles. Okay. So what happens? So let's look at the normal physiology first. So here's an illustration. So this is the myoneural junction. Okay. So this is the microscopic level. So this is the end of a nerve supplying our muscles, our skeletal muscles. So what makes muscle contraction possible are two things. We have acetylcholine. These are the acetylcholine molecules. Acetylcholine is a neurotransmitter. And then we have the, of course, these are the acetylcholine receptors, meaning from one end of a nerve fiber, muscle nerve fiber to the next. So acetylcholine is there, and then it'll be received by a receptor, and then it'll be passed on again. All right, so as long as this is normal, we have an equal number of acetylcholine with an equal number of receptors, there's a balance. So we can sustain a muscle contraction. So if I need to do this, so let's say this is a dumbbell. If I need to do this, I can sustain this because I have a normal, I have an equal amount of acetylcholine and equal amount of receptors. Okay, so as long as this is the balance is equal, then I can sustain muscle contraction. The problem here is the patient, because of this autoimmune disorder, there's autoantibodies destroying the receptors, these ones right here. So in figure B, do you still have an equal number of receptors here? No. However, we have no problem with the amount of acetylcholine. There's enough acetylcholine. We don't have enough receptors. Now, also on the under normal physiology, there's something called cholinesterase, which will destroy acetylcholine. Because otherwise, if I'm doing this, if the acetylcholine is not stopped, will my muscle contraction stop? No, my muscles will not stop contracting. So I need another substance, another enzyme to destroy acetylcholine when it's no longer needed. And that enzyme is called cholinesterase. You follow? Okay, so for muscle contraction, we need what two things? Acetylcholine and acetylcholine receptors. What is there to stop the muscle contraction when we no longer need it? No, something to destroy acetylcholine? Cholinesterase. Okay, so we need cholinesterase. So what happens again in myasthenia gravis is the patient develops antibodies against what? The receptor sites. Here, the receptor sites are destroyed. Not all are destroyed, but is there still a balance? No. We have enough acetylcholine, but not enough receptors. So therefore, can I sustain a muscle contraction? A repetitive movement, can I sustain it? No. Give me examples of repetitive movements you do every single day. What else? Talking. I've been talking since 1:30 p.m. I've been talking since 1:30 because you were the ones talking earlier. What else? When I eat, is that repetitive? Yes. Chewing and swallowing. What about blinking my eyes? Yes. Breathing. Yes, these are all repetitive. However, breathing might not be as affected because is the diaphragm a totally voluntary muscle? No. So it's not as affected. Remember, the disorder only affects voluntary muscles. So yes, it can affect the diaphragm to a certain degree, but not as bad as all other muscles. So when I'm eating and I have myasthenia gravis, could I choke?
Yes.
Yes, because I will grow progressively weaker. When I stop the activity though, my strength returns. Why? When I stop the repetitive activity, my strength returns. Okay, so here's the explanation. So this is normal. This is abnormal. So when I keep chewing and swallowing, can I keep up?
No.
No. So therefore, do I grow weaker?
Yes.
Can I finish the meal?
No.
I have to rest. So when I'm eating, every couple minutes I have to stop. I have to rest and then to catch up. Okay, so that the acetylcholine can catch up with the receptors. Okay, so that the impulses will continue. Because if I keep going, I can't sustain it because I don't have enough receptors. The transmission of the impulses from here to here is not continuous. Okay, because there's a backlog. So my weakness sets in the more I chew, and then when I rest, okay, let me take a rest. Okay, stop. There's still food in my mouth. Yeah, just stop. And then after a couple of minutes, okay, I can continue. My strength returns. Okay, and then it repeats itself again after another 2 minutes of eating. And again, stop again. Okay. So the problem becomes, what if the weakness is during swallowing part? Can I choke?
Yes.
Can I die?
Yes.
Yes.
Wait. So okay, the chewing stops.
Whatever repetitive activity. So
Aspirate, you're saying?
I could aspirate, yeah. So this goes on. So the manifestations, because we blink a lot, right? More than we think. We're not conscious that we're blinking, but are actually blinking a lot. So the early manifestations will be double vision or drooping of the eyelids will be the early manifestations. Then the patient will start complaining of bulbar symptoms, meaning when we say bulbar, these are the muscles involved in smiling, chewing, and swallowing. So these group of muscles here in your face up to your neck are called the bulbar muscles. And then we have limbs, of course, the arms and legs we use a lot, and the respiratory system will go weak. Okay, can I sustain the talking? No, I will get tired and I cannot talk for continuously. So those are the manifestations. Now, this is every day. Throughout the day, you'll have the symptoms. Can you hold a job? No, your employer will not understand that. Okay, I understand you can only teach for 2 minutes at a time. No, get out of here, right? Do something else. I can't have a teacher like that. So you have to seek treatment. Diagnosis, let's do the diagnosis first. There are a few other diagnostic tests mentioned here, but we will describe the Tensilon test. So this test mentioned in the first sentence is called the Tensilon test. Tensilon is the brand name for this drug, edrophonium chloride. What is edrophonium chloride? Remember earlier I mentioned about cholinesterase? What is cholinesterase again? An enzyme that will destroy acetylcholine. Okay. Now, since I don't have enough receptors and I have enough acetylcholine, and plus there's cholinesterase also, which will constantly destroy acetylcholine, what if I will stop cholinesterase from destroying acetylcholine? Therefore, even if I don't have enough receptors, I will have enough acetylcholine all the time because I'm taking a drug that will stop cholinesterase from destroying acetylcholine. Will that work? Because I can't create new receptor sites. Those receptor sites are gone. Okay, half of them are gone. I cannot create new receptor sites. However, I can change the physiology of my body by inhibiting cholinesterase, because cholinesterase will naturally destroy acetylcholine, whether you like it or not. But if I can stop cholinesterase from destroying acetylcholine, allowing acetylcholine to hang around more and longer to compensate for the loss of acetylcholine receptors, can that improve my strength? Yes. Now, we use this drug. This drug, by the way, will only be used for testing. What's it only used for? Because it only lasts for a few seconds. It does not work more than a few seconds. So does that mean if I'm taking this drug, it only works for a few seconds? I have to take this every few seconds?
No.
Well, that's what I'm gonna have to do if I use this drug for treatment. So it's only used for what? Testing only. So what will happen is the patient will be asked to do something. So let's say, okay, open and close your eyes repeatedly. So I'll do this. Okay, blinking, blinking. What will happen? Can I sustain the blinking?
No.
No, I will get tired and then I'll start to droop. Okay, my eyelids will start to droop. If once the drooping begins, I administer edrophonium chloride, which is, what is edrophonium again? It's a cholinesterase inhibitor, also called anti-cholinesterase. You can call it cholinesterase inhibitor or anti-cholinesterase, same thing. So if I stop cholinesterase by giving edrophonium, what will happen to my muscle strength? It will improve. So if the patient's weakness improves after injection of edrophonium, that is a positive Tensilon test. Tensilon is spelled Tensilon. Tensilon. Tensilon is again what? Brand name for edrophonium chloride. Any question about the test? Okay, we'll go back to the test later because there's two instances that we will use the test. So again, immediate improvement in the muscle strength after giving Tensilon is positive, is a positive test for myasthenia gravis. Okay. Now, the test I just described to you is done on a patient who has not been diagnosed yet, meaning the patient hasn't been taking any anticholinesterase agents yet. But this is the first time the patient sees the doctor, and then we do the test, the Tensilon test. You understand? Okay, so don't misinterpret the test. Okay, so this is only for, the one I described is for new diagnosis. Okay, so before this, the patient was having the symptoms. No, I can't finish a meal. I can't walk straight. You know, I have to stop every now and then. I'm so tired all the time. Goes to the doctor. Doctor performs Tensilon test. The doctors think, oh, that's the pattern of your weakness. Let's do a Tensilon test. All right. So that's, any question about the Tensilon? I'll come back to this shortly. So now the patient has myasthenia gravis. So now we begin treating the patient. First of all, there's no cure. So we will only give the patient anticholinesterase drugs every single day for the rest of their lives. Another, if the patient is having a crisis, we can give IVIG. And I described this earlier, right? Is this cheap? Very expensive. The cheaper alternative is plasma exchange. You guys mentioned fresh frozen plasma a few times today during your presentation. Why is a patient given plasma in the disorders you presented today? How does it help bleeding? How? What's in this plasma? Clotting factors are in there. What else are in plasma? Why is it given to patients with autoimmune disorders? It has antibodies also. So for this particular example, why is the patient with myasthenia gravis given plasma exchange? We're trying to remove the patient's own plasma, exchange it with another person's plasma. Because what is in the myasthenia gravis patient's plasma? What is in there? Why are we removing it? They have antibodies that is destroying their acetylcholine receptors. So we remove it, give them someone else's plasma. So are we helping with the symptoms? Yes. Does it cure it? No. These are all treatments. There is no cure for myasthenia gravis. Are we clear? All right. So here are the everyday drugs. So these are long-acting anticholinesterase drugs. So this will last a few hours. Pyridostigmine. Another is neostigmine. Neostigmine is used for, it has an IV form, but the PO form, the oral form, is pyridostigmine. So it's first-line therapy. It's cheaper. So this will be taken up to as much as 4 times a day. If a patient is active, let's say an athlete, are they stuck with 4 times a day or will they require more? They will require more. Okay, but the average person usually takes the drug 4 times a day. So typically every meal, and very important is we take this at least an hour, maybe 45 minutes to an hour before a meal. Why? Why do we give them before a meal?
So they can eat.
Very good. Is eating a repetitive activity? Yes. Can they finish a meal without this drug?
No.
No. Make sense? Okay. Why 4 times though? Why not? Because we eat 3 times a day. Why not 3 times a day? At night, you need another dose. All right. So the more active the patient may require more doses. Okay. But typically, that's how we take the drug. 45 minutes to an hour before a meal. Okay. Because the patient takes different doses, can we possibly take too much?
Yes.
Can we also possibly not take enough?
Yes.
Yes. When that happens, when we go into a condition wherein we're not taking enough anticholinesterase agents, meaning we're not taking enough pyridostigmine, or if we're not taking, if we're taking too much of the drug, both instances will result in a crisis. Okay. The crisis which results from not enough is called a myasthenic crisis. What do we call it again? If you're not taking enough, myasthenic. If you're taking too much, we call it a cholinergic crisis. What do we call if it's too much? Cholinergic crisis. The problem with the crisis is it's not easy to tell apart. Let me just go through here. I'll talk about the crisis when we get to the complications. Here are the other drugs. Look familiar? Do any of these drugs look familiar to you? Like the steroids, azathioprine. Where did you see them earlier?
Presentation.
And also in rheumatoid arthritis. Okay, so these are again, why? Because myasthenia gravis is also, it's also an autoimmune disorder. Okay. But the mainstay treatment is of course the pyridostigmine, the anticholinesterase agent. IVIG, I already described this earlier. Expensive or cheap?
Expensive.
Very or moderate?
Very.
Very, can run you hundreds of thousands of dollars. Okay. So here are a few contraindications. Let's say this is a anesthetic. Okay, so a few things. Now, this is the cheaper version. This is like dialysis. Remember dialysis? Okay. So if you do a plasma exchange, instead of, remember in dialysis, we put 2 needles, right? In hemodialysis, we put the needles into the patient, and then the blood is removed and then goes into the machine. And what does the machine remove before it returns the blood to the patient?
Taxi,
Excess water,
waste.
waste products, and electrolytes, right? Excess, anything excess we remove. Okay. If it's a plasma exchange, the same machine, but of course the machine is called a plasmapheresis machine. What is being removed? The patient's plasma. What are we giving in return? Someone else's plasma. Clear? Okay, so this is plasma exchange. But just like dialysis, how often do dialysis patients do it? 3 days a week. So about 2-4 hours, right? So same exact treatment. Yes.
We use synthetic plasma or?
No. It's a donor plasma. Okay, someone else's plasma. Have you ever donated plasma? Well, you should.
Blood, yes, but plasma takes a long time.
Yeah, just like platelets. But your reward in heaven will be much higher as well. Okay, simple. A few patients with myasthenia gravis can benefit from surgery, but this is only for a few, maybe less than 10%. No, sorry, 35% of patients can benefit from thymectomy. What is thymectomy? Removal of the thymus gland. Thymus gland is right here at the notch here, the base of your neck. You have the thymus gland. What is the role of the thymus gland? Thymus gland is thought to be, they take part in the immune system. They produce antibodies. So they discover, but not all patients have the thymoma. So some patients with myasthenia gravis will be checked. They'll do a CAT scan to see, do you have a tumor in your thymus gland? If you do, they'll do thymectomy. And for some patients, this may improve improve the symptoms. But again, not all patients with myasthenia gravis have a thymoma. So if you have one, then this will benefit you as well. Now let's go to complications. I'll do the complications of plasma exchange next week. We won't have time. Now let's do the 2 common complications, and then we'll call it a day. Here's the myasthenia crisis, which is again what? What kind of crisis is this caused by? Too much or not enough? Not enough. Not enough medication. What is this again? Okay, a crisis caused by not enough anticholinesterase drugs. What is the anticholinesterase drug? Pyridostigmine. Okay, pyridostigmine. So how do we know the patient has myasthenia crisis? Severe generalized weakness, wherein the patient is in respiratory failure, meaning they can't breathe anymore. Okay, they go into respiratory arrest. So what can trigger a crisis, a myasthenia crisis? Either the disease exacerbation, meaning the patient's not taking enough drugs, or something happened. Usually they got sick. Patient got sick, so do they require more or less of the drug? More. Obviously, the patient stayed with the current dose, they went into a crisis. Right here, so the infection, okay? The patient got sick, they got an infection. Here are other stressors that will cause myasthenia crisis. Okay. Whereas cholinergic crisis obviously is caused by too much. Okay, patient took too much of the anticholinesterase or pyridostigmine. The problem again is we cannot tell them apart. The patient will present the same way. Whether it's a myasthenic or a cholinergic crisis, the patient will present with generalized weakness. They will go into respiratory failure. There's some difference, but both patients will look the same. However, there's one will have extra secretions, etc. Now, since we cannot tell them apart easily, what will we do in order to tell them apart? The Tensilon test again. Okay, so let's go back here. So in this particular scenario, is the patient already taking anticholinesterase drugs?
No. In the scenario, yes.
In the scenario earlier at the start, was the patient already taking the drugs?
Yes.
No. Remember I told you when I described Tensilon? Yeah, this is a new patient, right? The description I gave earlier, the patient was a new patient, not taking any drugs. They had no idea what they had. We did the Tensilon to make the diagnosis, correct?
Right.
Yes? Yes. Now this time, the purpose is to distinguish now. So the first time we did it was to diagnose the patient with myasthenia gravis. This time we're doing it to distinguish. Is this a myasthenic or is this a cholinergic crisis? What is myasthenic crisis again? Not enough. Cholinergic crisis?
Too much.
Okay. What is edrophonium? What is edrophonium? What is this? Yeah, what is Tensilon?
That's a test.
What drug is it?
It's make it better.
It's an anticholinesterase agent. Long acting or short acting? Very short acting. Now, consider the scenario. Let's say I have myasthenia crisis, which means was I taking enough or not enough?
Not enough.
Not enough. If I'm given this drug, what will happen? What is the expected response? I will improve. My symptoms will improve. My strength will improve. I will breathe better. Correct?
Yes.
Okay. If, however, my crisis was cholinergic and you give me edrophonium, what will happen to me? Could I die?
Yes.
Yes, because you made it worse. I already took too much anticholinesterase agent. I already took too much pyridostigmine. Now you do this test, which involves more anticholinesterase agent. So what will happen to the patient? Symptoms will get worse. Could I die?
Yes.
Yes. If the patient's response is it gets worse, means what type of crisis was I having? Cholinergic crisis. Do I need to be saved?
Yes.
Yes, this is the antidote. All right. So if my crisis happened to be cholinergic, which again, what is the response when you do this test again? I will get worse because I'm having cholinergic crisis. So could I die? Yes, the drug to counteract it will be atropine. However, look at the this is the effects of the drug. If you give this to me, if I'm having a cholinergic crisis, this will be the effects. However, if the drug alone is given not for cholinergic crisis, the symptoms, the effects will be all opposite. All right. Okay. Any question? Okay, so review the recording.